Hello, my name is Dr. Jeffrey Gross, and I am from Recelebrate in the United States. And it's a pleasure for me to be invited to present to you as part of the 4th Global Regenerative Medicine Summit. The topic of my talk is subchondral exosomes for cartilage regeneration. So to understand this topic fully, we need to know why there is structural pain. And most of this pain, whether it's neck, back, joints, is caused by a problem of wearing down of what we call a joint. And that joint, as we all know, has a bony structure and usually some soft cartilaginous structure in between. Many of these have motion, although some have very minimal motion, like the SI joint. These joints can get into trouble from trauma, whether it's a single event or an accumulation of chronic repetitive events, and the end result is some type of degeneration, speaking broadly. And we're here at this event to speak to regeneration, the opposite of degeneration. This degeneration of joints, of course, is accelerated by a process of inflammation, and if that inflammation is chronic and ongoing, then the joint continues to degenerate and it can be accelerated by trauma. I come from the side of the spine, being a spine fellowship neurosurgeon. We have here one of the best examples of a joint. The vertebral bones each one has about 6 joints, the disc above and the disc below, and then 2 facet joints above and below. So 3 on the top, 3 on the bottom. Each disc, each level that is, has 6 articulations. The disc, though, does carry quite a bit of the structural weight and is subject to injury and serves as sort of a biological ball bearing, if you will. It's a prime example of what we're here to talk about today. So there's a biological problem. This is not just a mechanical wear and tear. There's an actual process by which the structures cannot help themselves, cannot heal themselves. These structures all started out as sort of a softer cartilaginous structure in the womb, and the bone hardens, but that bone is just not a hard structure. Of course, it contains marrow, and that marrow has a lot of biological activity. We're going to look at that closely. Inflammation, of course, can involve other joints too, not just the spine, but the process is rather similar, although probably less structurally interesting in non-weight bearing. Here in the finger, though, does get a lot of use. There can be sort of non-weight bearing structural degeneration and inflammation. The cartilage does then degrade as the joint is degraded and is inflamed. The cartilage or the synovial structures are sort of the symptom of the joint first. But as we know, with time, the bone above and below the joint or adjacent to the softer structures also suffers from part of that cascade of degeneration. In the spine, that's called the cascade of Kirkcaldy-Willis, whereby the disc loses its height, its moisture content, its viscoelastic property, and then the bone above starts to sense that through its mechanoreceptors and starts to lay down and deposit bone along its edge to increase its surface area, causing spurring. We also know that the bone is affected because we can see this on MRIs. The MRI does confirm that vertebral bones do not like losing the viscoelastic property of the cartilaginous discs. On the left screen, you can see the darkened or the marrow and the motic type 1 change, and on the left you see the bright on a T2 signal MRI. This is the same process. The bone marrow feels the problem and is showing it to us here in these clues. Again, these were identified by Dr. Michael Motic out of the Cleveland Clinic, and the motic type 1 does represent bone marrow edema and inflammation. So if the joint wears down bad enough, the bone on either side will start to feel this, and we can see it. It's not just the spine. We've seen this in knees and other joints as well. T1 is the low signal, T2 is the high signal. There can be enhancement, and again, type 1 is the inflammation. If it gets worse, type 2 is actually conversion of the red marrow, the good stuff in the bone marrow, the cellular activity in the bone marrow, to a fatty marrow. And then type 3 is even complete sclerosis, where the bone is nearly avascular, at least acellular. And this is where we get pain and problems, and causes quite a bit of disability worldwide. In fact, many of us have used, maybe broadly speaking, the phrase degenerative disc disease or degenerative joint disease. And this is probably not the best phrase, but it does represent a cascade of biologic changes in the spine. They're in the vertebra. They're vertebrogenic changes, although we tend to see the changes in the disc first. The health of the disc is coming from the local marrow. And repetitive trauma does cause this chronic reactive and sclerotic bone marrow changes, going through the modic types, 1 first and then so forth. And this is a vicious cycle, and the more degeneration you have, the more degeneration you will have. So that's why a trauma or repetitive trauma can accelerate a degeneration of a joint. In short, as the cartilage goes, the inflammation sets in, and that's the hallmark of the degeneration. We know the components of the spinal disc and how the pressure is placed on the nucleus contained by the annulus. And with loss of that, we lose the cushioning, the viscoelastic piece. And as we know, the disc is mainly water, and it has a number of collagenous and flexible proteins. That's the hallmark of a soft cushion, the gasket, if you will, of the joints. The cartilage, the disc, for example, has very few cells. So although many regenerative techniques involve injecting the disc, there's not as much biology going on in the disc or in the joints, in the softer cartilaginous joint structures. The biology is going on in the local bone marrow, and we're going to get to that. This is significant because the source of making a disc healthy comes from the local bone, not only for nutrients and vascularity, but also biology. These cells, particularly the stem cells in the local bone marrow near the end plate, is where those proteins are made, where those cartilaginous and proteoglycans are made and delivered. And we know this. We know it by blood flow. We know it by nutrients. We know there is diffusion going on. And this doesn't just apply to the spine, but the spine's a prime example. This is actually similar for most cartilaginous joints, particularly weight-bearing. But as I mentioned, degeneration is not just structural. It's going on at the cellular level and subcellular level through chronic inflammatory biochemical pathways. And the way regenerative medicine, stem cell medicine, approaches this problem is to address the inflammation pathways, to shut them off, reverse them into a restorative, reparative, regenerative pathways within the cell. There's a lot going on in terms of making collagen in the local structures. We know that discs under stress show degradation and degrading of the collagen proteins. We know there's dehydration, because if you don't have the proteins to draw on the water, then you won't have the water. As we know at home, if you've gone away on vacation, you come back to your kitchen, your sponge is all dried out in the kitchen. It's not flexible, it's hard. But if it's moist and you get it wet again, the sponge is squishy and flexible again. Same thing in the disc, same thing in other weight-bearing joints. And we know this because we can see it on the MRIs with the modic changes. And that can match with pain, but not always. Age is a factor as well. Although this talk is about the spine and the joints, the concepts that I give you here really apply broadly to cellular activity throughout the body. Aging is really accumulated inflammation, and we know this, and a wise person coined the word inflammaging because they really one in the same process. And that's why we can have two 70-year-old women looking very different, where one may have accumulated the changes at the cellular level that's manifests outwardly by activity, by energy, by appearance, compared to a more younger biologically younger 70-year-old. And we can see this in the spine. On the left is a healthy, youthful spine. You can see the hydrated discs with the white nucleus on this T2 MRI sagittal view. And on the right panel, you have loss of the water content of the disc. You have disc osteophyte complexes with herniations. And the two arrows at the L3-4 disc here show some modic changes, type 1 modic changes. So if we lose the disc height enough, and this is probably one of the thinnest discs here in the lumbar spine, we can see that we're starting to feel in the bone marrow the change. And of course, similar to degenerative disc disease, although I don't love that phrase, is degenerative joint disease, but that's really osteoarthritis. Particularly, it's referred to as a disease if it involves more than one joint, although how often have we seen that phrase even for a single joint, where we have, again, wearing down of the cartilaginous structures and reactive changes in the appearance, both on MRI and in real life, of the surrounding bony structures. I suppose it wouldn't be osteoarthritis if we didn't have the osteo in there. It should be really osteodegeneration. In any event, what can we do to slow or reverse this process? Hopefully without medicines and repetitive steroidal injections and without surgery, leaving joint replacement as a means of last option, not next option. Well, knowing that we reduce inflammation, we can reduce degeneration, and we really want to regenerate and with it have improved pain, we need to fight against the biology of inflammation and degeneration. I mean, young people do this all the time. You think about a 3-year-old who scrapes his knee and the scab heals within days, really. And why don't we in our middle ages heal that fast? We have the same cells, the same DNA. Why are they so dormant and sleepy? It's because they've accumulated inflammation, and they're busy fighting that off, and they're not in a reparative, restorative, youthful mode. And that's really the whole biochemical background of cartilage regeneration. And it starts from having the right milieu, having the right lifestyle, the reduced exposure to cellular stresses. And this could be diet, and not just what you eat, but when you eat it and how much of it, and what the components look like. Is there adequate protein, for example? It could be through vitamins, and not just the minimum required, but the optimal required. Supplements, maintenance, and attention to muscle mass and bone density, which is really a biochemical process to maintain that bone marrow with the red marrow, with the active cellular stem cells being happy marrow. Postural support, meaning not trying to reduce specific mechanical stressors on joints as much as possible. Could be meaning using the right running shoes or sitting upright in a work chair. Decompression, meaning taking pressure off, is helpful. That could involve restorative sleep. It could involve other techniques and maintenance. It could involve flexibility. And the last item would be regenerative biologics, which is really the thrust of the rest of this talk. And as I mentioned, the 3-year-old skins the knee and it's better in a few days. Why can't we heal like that? Well, with help, we probably can. Just beyond lifestyle factors, what we're really doing is when we're improving our own cellular activity, our cells communicate with their neighbors, and that signaling is important. Because we can take that signaling from a youthful person and give it to ourselves in our middle ages and have a boost, whether it's local or systemic, a boost of that cellular activity to program more youthful, restorative, regenerative, and not program in the pro-inflammatory degenerative mode. And to do this, we need to activate our sleepy and going to sleep stem cells and try to pull them back from senescence, or have the senescent ones become apoptotic and focus on the ones that are still there in our stores in the bone marrow. I will mention that although fat is also a source for stem cells, obese tissue is generally inflamed, and I'm not a big fan of stem cells from obese tissue because I believe those cells may be giving a pro-inflammatory message. So I like it from, and not that the bone marrow can't do that in the right setting of a systemic problem or disease that involves inflammation. I still think bone marrow derived stem cells are probably the best source. So we activate the stem cells through the epigenetic lifestyle changes optimally. This is really how PRP works too. We're taking the growth factors and re-stimulating our own cellular activity to some degree. It's also how autologous stem cells work, but even probably more efficient in delivering a cell-to-cell signal is just to give the signal. In this case, that's through extracellular vesicles, or exosomes, usually in the 50 to 100 nanometer range. And that's the thrust of what I've been involved with and am passionate about is regenerative medicine for spine and joints through stem cell activation using extracellular vesicles. As we know, back and joint pain are prevalent problems throughout the world. They cause great disability, great expense. The target for disc pain is not the disc optimally, in my view. It's the subchondral bone and the marrow of that bone just above and below at the end plates. In the vertebra, to be specific, where I have the asterisks here on this particular image. And I believe this to be accurate for other weight-bearing joints, and there's evidence of that from the French literature and in my own practice. And I believe that the motic changes we see here, the type 1 motic changes in the spine, for example, and we see this in other joints, are really giving us a clue as to where that bone marrow needs the most help. And the point of the spine is to deliver right into the vertebra to support the disc, to stimulate the cells that gave rise to that disc in the first place, to stimulate the stem cells in the marrow, to reinvigorate the production of collagen proteins, proteoglycans, and then bring in the water and restore both the structure and function of that disc to reduce pain. And that's the whole point of spinal regenerative medicine as it applies to the disc. And of course, we see this in the knees as well. It applies to weight-bearing joints. You can see here an MRI with thinning of the meniscal cartilage, tearing, and changes within the bone marrow adjacent. In fact, subchondroplasty is not new, right? It was done with cement for certain types of compression fractures involving the distal femur or the proximal tibia, but that uses cement, which changes the entire biology, kills the biology of that area, potentially puts additional stress upon adjacent bone. But now we have orthobiologic options, right? We have stem cells, we have PRP, we have everything. And although this is new, it takes our ability as clinicians to translate this from the bench to the clinic and to apply observations and use logic and bring together studies from one joint and try to apply it to another. That falls upon us. That's not going to be done in the lab. And that really is the clinical scientific method. And this is not new, right? We know that other species from which we have evolved or evolved parallel with have the ability to regenerate. Here's a starfish, for example. You cut off a few limbs of the starfish, it's able to stimulate something that regenerates limbs. This is not trivial. And our friend the axolotl, a very certain salamander from isolated lake in Mexico, has the ability to regenerate limbs as well. Salamanders can regenerate their tails, for example, and these are controlled by a certain set of genes which get switched back on. And they're not alone. Humans actually have the ability to regenerate the fingertip distal to the distal interphalangeal joint as long as the child is under 5 to 6 years of age. And this is not largely known, but it's it's a very interesting fact that we also have these same genes of limb regeneration. And what I'm talking to you today about joint and cartilage regeneration is only the tip of the iceberg of regeneration. You know, I got interested in this based on a number of exposures and experience and education, but also some observations. One was during my residency when I became aware of fetoscopic surgery for spina bifida. You know, through the magic of ultrasound, we could see children developing in the womb who did have spina bifida, and there became a procedure to actually go into the womb during gestation and close the defect. And although that's not specifically reparative, there's a known improved outcome in children who have closed spina bifida with neural deficits, that they have improvement and they have a better outcome. So the earlier you do that, the better. So why not do it in the fetus? But what was interesting here is children born having had this fetoscopic surgery in the womb were born without or with minimal scarring. So something is really magic about the amniotic environment, the fluid, what's in there, and tapping back into the most youthful sources of stem cell stimulation has got me interested in coming back to regenerative medicine as sort of a chapter 2 as a neurosurgeon. But what's in that amniotic fluid? Well, we have abundant and youthful stem cells. We have proteins, collagen, growth factors, and extracellular vesicles, the cell-to-cell communication. And this amniotic fluid contains umbilical cord cells and Wharton's jelly, placental cells. It's really a rich environment. So getting in more detail on the extracellular vesicles, these are really made by any cell, and there's a whole work and body of work on using our own extracellular vesicles as biomarkers for cancer, for other things. But what if we take the most regenerative, youthful, almost anti-aging message from stem cells from the womb and deliver them to someone who has senescent or sleepy stem cells, like someone our age? And that's what we're trying to do here through taking these MSC extracellular vesicles or exosomes and concentrating them and testing them, make sure they're safe and clean, and re-delivering them for anti-inflammatory, anti-degeneration, and therefore regenerative activity. And I believe that there are some exosomal signal in PRP. There's probably even more in a stem cell sample, or those cells when transplanted can deliver and produce and deliver exosomes and wake up our own stem cells as well as our own cells. But also the most fruitful source in my mind is the perinatal remnants. As I mentioned to you, amniotic fluid, umbilical cord, and its jelly, Wharton's jelly, and placental cells and matrix. What's in exosomes? I'm sure we know that they're chock full of proteins and growth factors and small proteins, which are often referred to as peptides, that are bounded by a membrane, a little piece of cell membrane, and that allows this to be delivered to another cell, and the cell adopts the membrane and lets the contents into the cell, almost like a viral infection, if you will. And these contents then get into the nucleus of the recipient cell to modify DNA transcription or programming. Instead of programming in an inflammatory, degenerative sort of, just kind of status quo mode, we can turn these into a repair and restore machine. And it's done through these exosomes, and they also carry microRNAs, so they can start producing proteins of repair, of health, of mitophagy, of autophagy. These proteins are abundant in youth, and that's why we get them from a youthful source. So that's another reason I like the perinatal sources over adult sources, because our adult cells are giving off an inflammatory signal. We want an anti-inflammatory signal. We want a restorative signal, which is anti-inflammatory. There are certain heat shock proteins that are found. As we know, many of these heat shock proteins are survival proteins. They're found during periods of hormesis, like calorie restriction, fasting, hot sauna exposure, cold plunges, and other slight stresses that build resilience in our cell populations, helping the senescent cells to become apoptotic and be recycled, as opposed to just hanging out and sucking up resources. And that's why we sometimes call them zombie cells, these senescent ones. We want cell turnover. But exosomes these days are generic. There will be not, there are already some examples. Last time I spoke to this, there weren't, but now there are, of actually designer exosomes, where we can even put them chock full of the right kind of proteins and contents that's more cell or tissue or result specific. Here's an example of a recently published article from Nature Biomedical Engineering of a specific designer exosome given specific RNAs for collagen replacement delivered to the dermal cells underneath the skin. This is a prime example of a cosmetic approach to anti-aging appearance through biology. What really drove me into treating the spine and joints this way is the work of Philippe Renaud, and I hope I pronounced that properly, whose 15-year follow-up study, quoted here from 2018. So now hopefully they're getting ready to publish their 20-year data. And what they did here is there were a couple different studies. Let me go to the next one here. This is the one I have in mind. This is where patients who were recommended total knee arthroplasty or knee replacement to join their study instead of having the knee replacement. And they had half the group had mesenchymal stem cells injected into the joint space, and half had mesenchymal stem cells injected into the subchondral bone above and below. And this Kaplan-Meier plot over the 15-year follow-up study shows that there was a initially complete salvage for the need for surgery in both groups. And the blue line, or the blue plot, shows that at 15 years there's somewhere in the low 80% range of the subchondral bone injection group of stem cells still did not need a knee replacement. So in other words, at 15 years, 80 to 85% of those patients still did not need the knee replacement that they needed 15 years earlier. In the joint injection group, they were not as successful. And I think the reason for that is the joint is very hypocellular. The meniscus is basically our biological rubber. And you can see that somewhere just below 25% of those patients went on to have failure at 15 years. Now, one would argue, well, why don't those patients go back and have another one, or cross over and then go have a subchondral injection? And you could. This study just doesn't account for that. But in any event, there is an obvious benefit from regenerative medicine for joints, and I think that significantly better for treating the surrounding bone where the biology of the joint is happening. And those were stem cells, not exosomes, but I think one can easily extrapolate. Stem cell therapy has also been used in discogenic back pain. These were disc injections. I believe I'm one of very few who's actually injecting the subchondral bone. But the results from the disc injection series did show improvement, and in some cases, improvement on MRI. Here's an example from the Patine article, the 3-year follow-up, where you can see on the right, now these aren't exactly the same sequence, but I believe there is some improved hydration on the right of the L4-5 disc, which is the white arrow on the right. So the way to do this best is have us all try it and create a study. It will be hard to do a blinded study. I don't think anyone's going to want the sham procedure or the control procedure. But the goal here is to rehydrate cartilage, to improve the viscoelasticity of joints, to reduce the inflammation, to reduce and hopefully, reverse osteoarthritic change. If bone can remodel towards degeneration, it can also remodel away from degeneration, and hopefully avoid and delay spine and joint surgery that would have been necessary at an earlier stage, pushing it off into the very, very latest irreparable stages. This is an example from the literature. On the left is a patellar cartilage. On the right is after stem cell treatment. 2 years later, there's some restoration of that. And then you can see from my own clinic, someone with a prior sports injury and prior arthroscopic surgery had grade 2 to 3 chondromalacia and chondromalacia patellae of the mediofemoral condyle as well. And then this is about a year and 7 months later on the right, after interosseous exosomes of the patella and of the femoral condyle. We have only mild residual cartilage irregularity and thinning. It wasn't even graded, so therefore at worst it's grade 1. So this is an example of cartilage restoration from injecting the bone, surrounding bone with exosomes. This patient is now pain-free, and there was an initial response due to the anti-inflammatory benefits of the exosomes, and then as the regeneration occurred, the pain reduction stayed. This person had trouble walking up and down the stairs and is now not having that trouble, and we're following her out. And regenerative medicine is not some future science fiction idea. This is here and now, and it's available, and we should do our best to offer it to people who we think we can help, to help avoid surgeries that can be put off or potentially completely prevented. I want to thank you very much for inviting me to participate. I would love to get to know you all. Please contact me. Reach out through LinkedIn. Tell me we met through this event, and I'd love to be your colleague. Please look us up on our website or email me if you have any questions. I appreciate your time. Thank you very much.